Hi, good evening, everyone. I am Anvesha Pandey, Deputy Director at Nat Health, and I'm extremely delighted to welcome you all for today's session of the Ayushman Bharat Digital Mission webinar series organized by Nat Health in collaboration with National Health Authority. Every week, we have an eminent speaker come on this platform and share their insights on one particular aspect of the ABDM. Today, we will be discussing how can doctors and hospitals adopt and use ABDM-linked solutions with our eminent speaker, Dr. Ajay Bakshi, who's an advisor at NHA and is also a neurosurgeon and tech entrepreneur. A very warm welcome to you, sir. We also have with us Dr. Uma Nambiar from Zeaden Life Sciences to moderate today's session. A very warm welcome to you, ma'am. With us today, we also have a very renowned healthcare expert, Dr. Alok Roy with us. Dr. Alok Roy obviously needs no introduction. He's the leader of the East chapter of Nat Health and is also our governing council member. He's the chairman of Medica Group of Hospitals, which is the fastest growing healthcare chains in Eastern India with hospitals in West and North Bengal, Jharkhand, Bihar, Assam, and Odisha. His vision was to gift to the people of Kolkata and Eastern India a healthcare facility that would be at par with international standards, but at rates that are affordable to all, which he has been successfully delivering. Though Dr. Roy specialized in nuclear cardiology from AIIMS, his passion lay in building and managing hospitals. He's the mastermind behind the currently running fleet of ambulances for road and street trauma services in Kolkata, Ranchi, and Jamshedpur. He's the past president of Bengal Chamber of Commerce and chairman of FICCI. I would now request you, sir, to give opening remarks for today's session. Over to you, sir.
Thanks, Anvesha. Welcome, Dr. Bakshi, Dr. Nambiar, and all those participants who have joined us today on this seminar. It's a third session of Ayushman Bharat Digital Mission webinar series organized by Nat Health in collaboration with NHA. We really appreciate the efforts of Nat Health with NHA in this mission and mention that private sector is united with the government in its effort. The health sector doesn't belong to private or public, it belongs to, and we both must contribute whatever we can do to ensure that we take care to the common man of this country. The series targets to bring together all stakeholders, public and private, on one platform to discuss widespread adoption and implementation of ABDM, various aspects of Ayushman Bharat Digital Mission. Implementation is like design, challenges, infrastructure needs, role of startups, etc. will be covered through a string of webinars. This series will serve as the myth buster for NDHM's futuristic vision and open doors for multiple stakeholders to willingly fuse with the vision of National Digital Health Mission. The series will cover many aspects of the mission every week and try to build a common awareness for us to collaboratively adopt the digital health roadmap of India, which is nothing but the future. There's no way we cannot adopt it, or there's no way we will not be part of it. Sooner we become part of it, better it is for all of us. Several myths and misinformation will be dispelled as the key architects of digital health strategy will answer all questions. Today, we are going to cover how can doctors and hospitals adopt and use Ayushman Bharat Digital Mission linked solutions. With Dr. Ajay Bakshi, neurosurgeon, tech entrepreneur, digital public goods and advisor, NHA. The session will be moderated by Dr. Uma Nambiar. With this, I hand over to Dr. Uma to take it forward. Thank you very much.
Thank you, Dr. Roy. Welcome, Dr. Bakshi. It's a pleasure to moderate this session because we know and we are all equally aware that this is an important, I would say, step in our country that is being taken. It's a great challenge. It's not easy at all to implement digital solutions across healthcare in a nation, which is as big as our country. But government haven't taken this very bold step and the challenge. the onus of making it successful is on all of us, and the healthcare providing bodies and all of us are responsible for the success of this. And the success has to, if it has to succeed, it is all of us who has to participate. So I welcome Dr. Bakshi to address this very important aspect, which is the fear that the doctors have to adopt digital solutions, and also what is the role and how we need to participate in this. So Ajay, over to you.
Thank you. Thank you, Dr. Uma. Thank you, Dr. Roy. Thank you to Nat Health and NHA for inviting me. Am I audible, Uma? Is this clear?
Yes, very much, very well. Yes.
So I will share a few slides to start with, but the story that I'm trying to tell is not so much a lecture, it's more a continuation of a conversation. As you know, that this discussion on what used to be called National Digital Health Mission, which is now renamed as ABDM, Ayushman Bharat Digital Mission, has been going on in the country for the last 2-3 years. There have been documents published by the NITI Aayog, by the Ministry of Health, by the National Health Authority, and consultation papers have also been published. So I won't go into all the details of what has been published, but I want to start the conversation which is specific to doctors and hospitals. So that's the goal of today's conversation. And if I'll just share the screen, is this visible to all of you?
Yes, it is.
Okay, thank you. So as said, the NDHM architecture, which is now called ABDM, is well defined, but just to recap it very quickly, India has made a lot of progress at what is called the JAM Trinity, the Jandhan, the Aadhaar, and the mobiles, and other digital public goods, which enable us to have these bold ideas that how do we connect the whole country for digital healthcare. On top of this existing innovation that has already happened, digital registries, which will essentially give a digital identity to every player in the digital mission, which means it could be a doctor, it could be a nurse, it could be a facility, a lab, a pharmacy, a pharmaceutical drug, and of course, the citizens. So those will be the registries. There is already a lot of effort and implementation that has gone on health information exchange and consent managers. This basically means that every individual who has a health ID can also start storing their own health data behind that health ID under control of the citizen. And therefore they can give a consented access to that information to their doctors, to their hospitals as the need may acquire. And then this is not possible in most countries in the world, and India is actually innovating in building what is called a true digital personal health record. So that's also a topic that is not the focus of today's conversation. And there's a whole bunch of stuff going on in health claim standards, health insurance efforts are also going on, which again is not a topic of today's conversation. Today we're going to talk about unified health interface and how it relates to doctors and hospitals. So I'll start that discussion with a case study. And we have built this case study to illustrate a very important point, in fact, a very radical point. So kidney disease is a common problem. And just for those of you who are not doctors, kidney is essentially a filter which filters blood, removes toxins, and throws out all those toxins in the form of urine. The efficiency of this filtration is measured by something called GFR, glomerular filtration rate. And if it is above 90, it is normal. And if it is below 15, it ends up being called CKD, chronic kidney disease, or end-stage kidney disease. So there is a reason I'm telling this, because India has around 110 million patients of chronic kidney disease. Yes, that's a surprising number. It's around 8% of the population. It's a very large number. And these are rough estimates, but it is thought, and we have spoken to a few experts, that around 55% of those patients can be managed by GPs, which are or internal medicine doctors, which are talking about patients who are in the early stage. But as the patient progresses towards ESKD or end-stage kidney disease, they need a nephrologist. A nephrologist is a kidney specialist. And a timely intervention from a nephrologist can reduce the progression of disease. Why is this important? Because if you don't control the disease before the GFR becomes below 15, patient needs dialysis, and dialysis, as many of you know, is a lifetime kidney replacement therapy, and it's very expensive and it's very painful for the patient to undergo for the rest of the life. By the way, dialysis is a very major expense for Ayushman PMJ scheme as well. Now, the problem is that India has only 2,600 nephrologists, and most of these are concentrated in the top cities, which is not surprising. We know these things. The bigger problem is, despite a lot of effort in education, building medical programs, building medical colleges, India still graduates around 150 nephrologists a year. So if you compare India's 2,600 with United States 10,000, you can calculate that in 10 years, we'll have another 1,500. We will still be short of USA numbers today. In 20 years, we'll still be short. So training more doctors is not easy, and India is doing what it can do. But if these 2,600 nephrologists were to take care of these 48 million patients, each doctor will have to see around 18,000 patients a year. And then given that these patients are spread out all over the country, it's a physical impossibility. And this has been the challenge for Indian public health policy for a very long time. Shortage of doctors, difficulty in reaching patients. Now, the radical idea here is, it is now possible to do this, create this access digitally. Let's see how that will work. So if you have these 2,600 nephrologists over here, and if you have these 48 million CKD patients who need nephrologists, I'm not talking about the 60 million who are already well managed by the GPs and the internal medicine doctors. And if you build this digital bridge called the UHI, let's just do the numbers very quickly. If each nephrologist opts to see CKD patients via UHI through a telemedicine consultation and gives 5 to 6 hours a day, which is actually not difficult because most doctors see patients, especially the nephrologists, see at least 7 to 8 hours or maybe even 9 hours a day of patients. 5 to 7 minutes per consult per patient, along with the primary doctor of the patient. So there is a group consult idea that the two doctors can, the patient and primary doctor can come, get the specific points of reference from the expert specialist doctor, and then implement that. This will lead to around 47 million patients being covered. Now, to those of us who are watching Indian health progress over the last few decades, this is almost magical because for the first time, yes, these are stretch assumptions. Yes, most likely these won't happen, but at least there's a roadmap to making this happen, where a patient sitting in a remote part of, say, Madhya Pradesh can call Dr. Bhupesh Modi, who's a very well-known nephrologist in Bhopal, and get advice about his very high sugars and the special anti-diabetic drugs that are proven to reduce progression of CKD that only nephrologists generally are well versed with. That is not possible, and that's why we put his photo, because some of these ideas came from Dr. Modi himself, Dr. Bhupesh Modi, that he does this. But how do we scale this to 2,600 nephrologists around the country to create this 48 million CKD patients now having access to expert doctors, which if you go the traditional route, even 20 years later, we will not have enough doctors to take care of these patients. So that's the magic that we are talking about. It's not easy. It's going to require a smooth technology experience. It's going to require a lot of patient managed experience improvements. And of course, the whole system needs to be sustainable, and therefore compensation is also needed. Now, that case study can be replicated in disease after disease. Cardiovascular disease, we don't have enough cardiovascular surgeons or cardiologists. Respiratory disease, we don't have enough pulmonologists. A neurological disease, we don't have enough neurosurgeons or neurologists. The point of this slide, and this is coming from Government of India data from a survey that was done in 2017, 2018, is that nearly 70% of diseases that Indians suffer from, for which they go for an outpatient consult, are chronic diseases now, okay? And chronic diseases happen again and again, and they need multiple touch points, and they're progressive most of the times. So therefore, the story that I've told for nephrology can also be told for neurology, for cardiology, for pulmonology. The other point of this slide is that a lot of patients that doctors see in their clinics are their follow-up patients. Almost 80% of the volume of most doctors, by the time they reach mid-career or towards a more senior level, the doctors are more senior, more than 80% of the patients are repeat patients, and new patients are generally 20% of the volume. Why am I saying this? Because a lot of telemedicine efforts have gone in solving this 20% problem. How do you find new patients for doctors who are willing to do telemedicine? And not much effort has gone in enabling a smoother experience for this 80% of the chronic disease management. And then that's some of the core things that UHI is trying to solve. Now, again, why is this a challenge? There are multiple choke points in the current system, which prevent the patient from reaching the doctors at the right time with the right expertise. There's a discovery problem, there's a geographic availability problem. If I'm in a village and there is not a cardiologist in 200 kilometers, there is a temporal availability problem. Okay, I get a bus from my village, I go to the bigger town, but is the doctor there in town during those 3 days that I'm there? How do I get transportation? How much money do I take with me? Do I take 200 rupees, 2,000 rupees, 5,000 rupees? There is no way for a new patient to know how much he's going to pay. Does he have money to even pay? Can he afford this? And by the way, by the time he reaches the doctor, some of his reports are sitting at home, some of them are on somebody else's phone, and the doctor does not have access to the complete records. So we are actually excited that UHI will potentially solve for many of these problems by building a reimagined system that overcomes some of these choke points. And this, again, in our view, is a very big idea, because the traditional approaches of training more doctors, giving them incentives to going into smaller towns, is working to a very small effect. But as we have shown earlier, that's going to take decades, and we're never going to be able to catch up, because remember, our disease burden is also increasing. So this idea of democratization of doctors' expertise is actually a central idea of UHI, and therefore there's a lot of potential benefits that doctors can get from there. Now, there are a lot of bad things that COVID did to the world and to India, of course, and I don't want to go into those details. But one good thing COVID did was it demonstrated that telemedicine can play an important role in Indian healthcare. These guidelines, believe it or not, were published on 25th of March. Telemedicine practice guidelines were published by the erstwhile National Medical Council. It had just begun to do the work as a National Medical Council. And before this, telemedicine was actually illegal in India because of a Bombay High Court judgment. And these guidelines gave the policy cover to doctors to successfully manage patients on telemedicine. And we have talked to a lot of doctors. They've also said that, yes, patients have become more willing to do online transactions. Doctors have become more willing and more confident of being able to take care of their patients, at least some of them, online. There's lots of things you can't do on telemedicine, and that's also well recognized. But there is a whole lot of care that can be delivered through telemedicine that is now becoming possible. Now, one more important national statistic, which again comes from this NSS 75th round survey, is that if you see the volume of outpatient consultations that happen in India, it turns out it's around 60 lakh a day. And on a daily basis, 18 lakh of those happen in government, and all the rest of them happen in private doctor, private hospital, trust hospital, and some informal system. So as Dr. Roy said earlier, private sector has a huge role to play in delivering healthcare in India. And the burden of making improvements is on both the government sector as well as the private sector. But the important point on this slide is that despite these physical outpatient volumes, remember this is 2017-18, so this is pre-COVID, only a tiny fraction of this is currently digital despite COVID. So we talked to many of the telemedicine players, including eSanjeevani and many of the other private players. And we estimated that not more than 2 lakh per day out of the 60 lakh a day is on organized telemedicine. We expect that there may be another 2 or 3 lakh on things like phone calls or WhatsApp chats and WhatsApp video calls, the informal, non-organized healthcare systems. So it still remains a very tiny number. And we have studied in detail why that is so. If there is such a big burden of disease, there are availability of doctors, why are patients not using more telemedicine? And we learned from both sides, from patients and doctors, that patients are worried about the doctor. Is the doctor even real? How do they trust that the voice on the other side of the phone or the image on the other side of the video is actually a doctor? So that's a big issue. Doctors are reluctant to enter into endless price negotiations. Patients say, oh, I paid you last time, do I have to pay you again? And there's a lot of confusion about this whole issue. Data issues with third-party platforms. As said earlier, doctors were not comfortable using digital. So long story short, we analyze the current system and we are proposing a redesign of the system that is doctor-centric and has a very important feature that we call trust by design. What that means is that since many times the patient and doctor will be in different locations, how do you build a system that engenders trust, that increases trust, rather than just assume that trust will happen automatically? Because without trust, the whole system falls apart. So shifting gears from an analysis of what the system is and the current Indian healthcare system's challenges are to what the solution is in UHI, and then I'll, towards the end of this section, talk about what are the potential benefits for doctors and hospitals, and then we can have an open Q&A. So the synopsis of the UHI conceptual model, the way it has been designed in collaboration with many of the public policy experts that have contributed to this, is that the doctor is the gateway to the health services. This is a very important insight. This is not unusual to this audience, but believe it or not, when we talk to technology players, sometimes they're surprised by this, because technology players in other industries go directly to consumers, whether it is retail, whether it is travel, whether it is banking, they know how to get to the consumer. And our insight is that unless the doctor is convinced and the doctor is excited and doctor is confident that he or she can deliver good care, the patient will not be able to get the sort of care that he wants, right? So there's a lot of focus on how to make this believable and something that a doctor actually wants to do. So I won't go into the details of this, but that was the essential message from this. And a lot of thinking has gone in completely redesigning that experience of the patient finding a doctor, booking a doctor's consultation, doing the consultation, getting the prescription, making the payments. All of that has been completely redesigned. And not only has it been redesigned for a one-on-one interaction between a patient and a doctor, we have also come up with some new ideas which are not possible in the physical world. So there is an idea of a group consult. What if a GP needs his patient for lower backache to see a neurosurgeon? Today, the GP will say, go see a neurosurgeon, write on a prescription form, and the patient will go hunting for a neurosurgeon. In the digital world, it is possible for the GP to say, well, I know Dr. Uma Nambiar is a neurosurgeon and I want to call her to a joint consultation so that she can look at your MRI and advise to you what you need. And so therefore, a new modality comes into existence. Similarly, there can be a modality around emergency. Suppose you have a snake bite and you don't know where to go. Can you find a doctor in your local region who's available on UHI there and then and tell you that, okay, in this dispensary, an anti-snake venom is available and you can rush there. So there are things that digital can do and innovation that can happen, which is actually not possible in the physical world. And that's why this is very exciting. Now, going back to the point around trust that I made, that we have talked to a lot of people and put in a lot of design principles, as we say. And I'll just take 2 minutes to go in a little bit of detail in this, because this will resonate with the hospital leaders and the doctors on this call. So the first trust feature is that only doctors validated by the health professional registry will be allowed on this. I'm saying doctors here, but eventually this will expand to all healthcare professionals, including technicians and nurses and physiotherapists and all of that. Very important point for patients to build trust. The second thing is open network principle builds trust as patient generated filters. So patient says, I want to meet a lady neurosurgeon who speaks Tamil and who has at least 15 years of seniority. And then that is how the rank order of the doctors will happen, rather than by which how much money the doctor has paid to that the technology player to increase his or her ranking. So I think this is also an important trust principle. The third one, very important, transparent pricing. No bait and switch. We all have heard stories of, oh, this will cost you only 500 rupees, but in the end, all put together, the patient ends up paying 2,000 rupees in lab tests and all of those. So there's a lot of transparent pricing efforts going on. These are still work in progress, and this is going to shape up over the next few weeks and months. Patient will have to prepay in order to book appointments. Now, this is a novel feature. This does not happen in most systems today, WhatsApp or organized, because talking to doctors, there is an enormous amount of frustration in doctors that patients don't pay. Later on, there are blank bookings. They have to negotiate. They have to fight with patients. They have to argue with patients, something that doctors hate to do. Doctors are not trained to be businessmen. They're trained to be professionals, and they expect that the fees matters will be sorted out. And that is unfortunately not happening in the current telemedicine systems. Even more important, fair and transparent market rules for both sides. What happens if the doctor doesn't show up? What happens if the patient doesn't show up? How do cancellation work? What happens if there's a dispute? So there's a lot of thinking going on this. And good news is a lot of these features have been solved in other systems like financial services, like UPI, like accounts aggregator. So some of that knowledge is also coming to UHI. And then the sixth feature is probably one of the most important, and this is a very big topic, so I won't go into details, but India is the first country in the world that is building a citizen-centric data empowerment architecture. That is what DEPA stands for. Data Empowerment and Protection Architecture. In United States, most of the data is owned by large corporations. In China, most of the data is owned by the government. In Europe, most of the data is locked into a GDPR vault and not available for anybody. India is saying that let the data be with the patients, who will have a consent mechanism to create value from that data. And this is already happening in UPI and in accounts aggregator. And we hope that some of this will also transfer to UHI. So these trust by design features will, we feel, go a long way in making the UHI a success in India, because this is sorely lacking right now. Again, I won't go into details. A lot of these market rules have been mentioned in the consultation paper. Some of them are still work in progress. We'd love to get more feedback from any one of you, and you can write to the National Health Authority. Now, just a little bit of technology towards the end of this presentation. Very important feature of the whole UHI architecture, that this is not a government system. This is not designed by NHA, and eventually it will be shepherded by NHA. Think of it that way. But the shepherding will happen through the standards and protocols that are written in the UHI, not by the government building something out itself. The government may build out a reference app, just the way the BHIM app was a reference app for UPI. But PhonePe, Google Pay, Paytm, and so many other apps have actually done better than the BHIM app, and that's perfectly fine. So the tenets of the architecture is that everything will be an open standard and available for multiple parties to participate in. Interoperability is a very important feature, and huge efforts are going in to avoid a lock-in by a technology player. And some of these technology features, I won't go into too much detail. There is going to be a tech session later on by Mr. Kiran Anandam Pillai. And we like very much the analogy of a space station. A lot of excitement in this area, but why is this relevant to UHI? Because the International Space Station is made up of 16 pressurized modules from 4 different countries and regions. And when the docking happens, the space station works. And it's a life-threatening problem if the docking does not happen. So similarly, we think of the various modules of UHI, the discovery module, the booking module, the health professional diary module, the consultation module, the backend orchestrator module. So these are, again, I won't go into too much of tech details. These are modules that the tech teams have designed, and now at least 6 wave 1 partners from the Indian industry are working to build these modules in a way that all of them are interoperable, and anybody else can also build more such modules. So remember, there is no lock-in, there is no monopoly. Everybody can participate, but the standards are such that there is a lot of interoperability. Today, any 2 of us can set up an email, a new email, and send an email to any email server. It doesn't matter. It's not that Gmail can only go to Gmail and Hotmail can only go to Hotmail. Similarly, and the vision here is that any doctor should be able to see any patient, and vice versa. Any patient should be able to find any doctor and therefore have a meaningful clinical interaction, whether it is through a video or it is through a report review or it is through a group consult. Those are all innovations that need to happen. So that's it on the current situation. And I was reminded of this famous quote that it's very difficult to tell what is going to happen in the future. And that's what Nat Health has requested me to do, that how will doctors use this? And the honest answer is, I don't know, because a lot of innovation will happen. And most likely what I say now is not what will happen, but what I'll say now is more to trigger some thinking and to invite more conversation. And just after these two last slides, I will keep quiet and then we'll open to questions, Dr. Uma and Anvesha. So the first slide is about doctors, and there are 2 or 3 ideas here. The first idea is, and some of you who are from healthcare know this, that a fresh doctor who's graduated, say as a nephrologist, generally at the age of 30 to 32, takes at least 15, more likely 20 years before that doctor reaches full capacity of outpatient consultations. Why does that happen? Because as said, most of these doctors are in large cities. Large cities happen to have a lot of other nephrologists or neurosurgeons or cardiologists. And most of the disease burden is not in the large cities. So the sync up does not happen. So we actually feel that once search becomes national through UHI and it becomes frictionless, which means that the patient decides which sort of doctor he wants to see based on what his local GP has told him, this will accelerate the practice ramp up for, especially for younger doctors. It may not matter much to the busier doctors. And in fact, I've spoken to doctors who are already in busy practices, and they told me bluntly on my face, Ajay, I'm not interested in telemedicine. I have no time. And that's fine. But there are a bunch of doctors who are in the 30s, early 40s, who are still having time and some sort of a excitement to contribute to healthcare of India, to do paid consultation. Remember, this is not a free seva. This is something that a doctor will set the pricing for. The patient will agree to pay that, and those trust by design principles will kick in, and it will be a very smooth experience for the patient as well as for the doctor. So I think this is going to be a very big idea for both for the younger doctors as well as for the problem of shortage of doctors that India is not going to be able to solve even for the next few decades, as discussed earlier. The second big idea for doctors, and again, many doctors are very excited about this, is that we don't get patients' data in one place when we are making the clinical decision today in the physical world. And the digital PHR will actually make that possible. And that's a big deal. Guess what? This is not even possible in the United States. Just last week, I was talking to a former colleague in Japan, in Tokyo, and he told me that he had a young child, and the child's data is in 3 different hospitals. And even in Tokyo, he does not have an integrated view of his own child's data. India will make that possible, and doctors are very excited that that will improve the quality of care because less mistakes will be made and better decisions will be made. The other problem for doctors is, I'm a neurosurgeon, I've done a surgery for you, you go back to your hometown in Ranchi, and then I don't see you for a few years. And that's a problem because sometimes things may happen. You may have another disc at a different level, for example. So a small video consult will enable a continuity of care, which otherwise becomes forgotten and then until it is too late. And then the third point about quality of care is increased collaboration. I already talked about the group consult earlier. Coming to, it's hard to predict what's going to happen in the future. I actually think a lot of innovation is going to happen. Doctors are extremely innovative, and in fact, Indian doctors are extremely entrepreneurial. I have worked with some European doctors, and they actually tell me that, look, in Europe, we don't get paid unless we do a certain protocol. So don't even talk about innovation. We're going to do what the insurer asks us to do. And that's what a lot of European doctors have told me. But Indian doctors are very passionate about improving care for their patients. And once they get these tools of UHI at their fingertips, I actually think a lot of innovation in the form of either startups or collaboration with technology players will happen. Disease management programs, collaborative programs, digital virtual practices? What is to prevent a group of 5 classmates, say from AIMS, to say, okay, we'll form a digital virtual practice since we know in each other. And we may be in 5 different cities, but we'll see patients together and we will take care of them together. That's going to be possible once UHI is up and running. And then finally, very important, a lot of patients come to India from Nigeria, from Tajikistan, from Mongolia. I've run large hospital chains, and this is a big business and a matter to be proud of for Indian doctors and Indian hospitals. And their connectivity, and they're as much as our patients as Indian patients. So their connectivity, their improved quality of care also improves with UHI, because UHI is not only going to be an Indian system, it's going to be available to external systems also. So these are 4 ideas, and I'm happy to hear more thoughts from the audience once we open for Q&A. And then the very last slide is, what does it mean for hospitals? And again, these are early thoughts, but we actually feel that the national footprint for hospitals, which will happen because you are now, your doctors as a hospital are now discoverable by the whole country. And yes, for surgery, maybe your catchment area will remain limited, but some of the super specialty hospitals do attract patients from thousands of kilometers away. And that becomes easier when the doctor feels better connected to the patient and vice versa. So definitely, I think there's going to be an increase in catchment area. What is to prevent a hospital in Calcutta from opening a digital branch, say in deep inside Bihar, from where they get a lot of patient footfall? Dr. Alok Rai is here. I'd love to hear his thoughts about this. But digital branches basically mean that you have trusted doctors in that geography where you're opening a digital branch, but then these doctors are well connected to your expert doctors. So the patient is getting what he needs, but the hospital is also able to reach out through its digital channels in a more effective manner than the current fragmented digital system enables. Marketing cost is a big problem for hospitals. They spend a lot of money on referral channels, on international channels, on online advertisements. And as a doctor who is running hospitals, I actually think that needs to be reduced, because the patient should be able to discover you and patient should be able to come to you. I've always struggled with a hospital having to spend money to attract patients in a country where there is an overburden of disease. So I think there is something not fitting well in that equation. And what's not fitting well in that equation is all those choke points that I talked about, all those lack of trust features that I talked about, and some of those will be improved by UHI. And therefore, we actually predict, not in the beginning, it will take a few months, probably years, but eventually the marketing cost for hospitals should reduce, and the ramp up, just the way a young doctor ramp up, will be accelerated. We also feel that if UHI does well, the ramp up of hospitals will also accelerate, and that will significantly improve the economics of hospitals. Right now, the payback period for a new hospital is upwards of 10 years. It's only after 10 years that a brand new hospital even begins to return some money for the investors who have put in that money. And that's in a good scenario. In a more likely scenario, it might be 15 years. And given the way the global capital works today, there is very little patient capital that is willing to wait for 15 years. And the hospitals are becoming more and more expensive. So this accelerated ramp up via UHI facilitation and removal of friction is going to be a big thing for hospitals. Of course, as said, it has not happened yet, and it's going to take some time. And the last thing, actually, this idea came from some of the senior leaders of large hospitals in India who get patients from far away. And they say the same thing, that the patient comes in, flies in, sees our cardiologist, gets a complicated procedure done, and then really struggles to connect with the doctor. Yes, they do phone calls, and many hospitals have their own proprietary telemedicine systems. I'm not saying that's not there, but it is still creating a lot of friction between the doctor and the patient, and removal of that friction will enable hospitals to also give improved continuity of care. And of course, we talked about innovative digital models in the context of doctors. We think it is equally and probably more relevant for hospitals to build disease management programs. We have even discussed at length the lack of preventive care in India. And we actually feel that UHI will create new models by which hospitals could support preventive care through digital channels at a much lower cost then what is otherwise a preventive health checkup, lab tests, etc. So there's a lot of new technology coming in, biomarkers are coming in, and digital preventive care can also be a wave of innovation once UHI has become successful. So I've taken a lot of time, Uma. I think I'll stop sharing. That's my contact information. If anybody wants to send me ideas, send me criticisms, send me suggestions, brainstorm on something, I'm available and would love to take this conversation forward with the entire audience. So over to you, Uma, and I'll stop sharing now. Thank you so much.
Yeah, thank you, Ajay. This is a wonderful talk, and I think it's a very good initiator where the doctors can understand what is happening, because what we normally see is at this moment the tech people are far ahead in this game, but the doctors still have not realized what the impact of this is going to be, and what the impact on it or the negative impact on them will be if they don't adopt to this technology. So that is very, very important. So I have, one question which I want to ask you before we go into the questions is, one second, is that, when you are running a hospital and you've been there and we are selecting these IT solutions, you find that the buy-in of the doctors very often is very limited, if at all it is there. And how do you suggest that the doctors, at least the senior management, decides on what solutions to buy and how to get the technology adopted by the healthcare workforce, primarily the doctors and the nurses, so that it can be successful?
Sure. So can I be very undiplomatic? Or I know this is a public channel, but I am still going to be undiplomatic, because I've heard this criticism from technology players for a very long time, that doctors don't like technology, they are averse to technology. Why? Because they don't adopt EMR very well. And my counter to that has always been, doctors use CyberKnife, doctors use PET scans, they understand Gamma Knife, they understand robotic surgery. So how come they know all the technology, but your IT technology they don't know? The answer is, I think a lot of IT technology is designed either for the hospital or for the insurer. If you see the US system, the EMRs are designed to track transactions, to send codes to the insurance companies. They are not designed for doctors, and 50% of US doctors are now having what is called a meltdown, a physical breakdown, because they're just tired of entering stuff into the EMR. So the EMR was not designed for the doctor, right? So that's why doctors struggle, because it doesn't genuinely improve the doctor's life. There is all this thing about safety, you will have triggers and you will have stuff, and yes, that is there. But what the tack we have taken from UHI design is, let us see, and it's a narrow tack, it's not all of health IT. I am the first one to say that the presentation I have made is about a very narrow, how do you improve digital interaction between doctor and patient? But we hope once this is successful, it is not successful yet, that IT technology companies who are building solutions for healthcare will put the doctor and the patient in the center and not the hospital and the insurer. Now that's fine, those are needed. I'm not saying those are not needed, but any system which is causing a physical breakdown of 50% of your doctors needs to be challenged. And that is actually happening in the US. So it's a convoluted answer to your question, Uma, but my answer
is... but it's the right answer, because I also feel the same, that so far we face the problem where the doctors have to forcefully use the technology. It is like, they are saying, you use this because I've designed this process for you. Yeah. It has to be the other way around. The tech has to build for healthcare rather than healthcare has to go and follow what the tech sort of dictates to you. So that's where that's a major concern. So there are a couple of questions. Let me just take from the audience what has come. So one is whether the private doctor can use the Ayushman telemedicine platform. This is from Dr. Yamini.
So the Ayushman telemedicine platform is a digital public good. It is an open protocol that will allow any technology player to build a service for any audience. So the answer to that question is yes, of course, private players can use and will be expected to use. If 70% of healthcare in India is delivered by private players, it will be very suboptimal to design a solution that is not available to the 70% of the providers, right? Now, how that will happen is just the way UPI is a platform built and managed by NPCI. NPCI is a governmental entity. But Google Pay is a private entity. When I go to buy a banana from a vendor, I am a private entity. The banana seller is a private entity. So there is no, the only thing is we need to have our UPI handles and we need to have our consent mechanisms. So all of those are being built up. In fact, my vigorous answer to that is if the private players are not able to use it, then it's a failure. So it has to be designed in such a way that the private players are able to use it for any patient anywhere in the country.
That's right, because it's not just for the government hospitals, it's for everyone. So there's a question on how are we going to increase the accountability of government hospitals towards the taxpayer through this. And in fact, I would add a bit and I'd say it's not just the government hospitals. How do you think that this will improve accountability of hospitals?
Yeah. No, so, okay, let's take a very specific example. One of the biggest complaints about government hospitals, and I've worked in many of them, is doctors don't come on time. They're not available. And it is very hard for a government, say, medical superintendent to counter that because the physical inspection of who's coming on time and who's late and who's seeing how many patients, he or she doesn't have that data. In digital, say, assume that, okay, there is a district hospital in a district which is having this e-Sanjeevani module for digital consultations. The administrator will know that evening that how much was the wait time and which doctor did not show up, and therefore can take corrective action if that corrective action is possible. So government accountability is a very complex question because if you can't fire that doctor, if you can't reprimand that doctor, then anyway corrective action is not going to be effective. So I think there are other issues. But the point is, digital makes transparency. Transparency leads to accountability. So there is a possibility of increasing accountability, but other things need to be put in place for that to happen.
Yeah, and definitely, I think accountability, ethics, transparency are all going to be eventually part of our system if we really get started. And the whole distrust with the medical community, where people are not trusting their doctors anymore. I think that's an atmosphere that is going to change completely. So there is another question about, did we think about capping the price and not misusing to tax the patient?
Sorry, I didn't get the question. So who's thinking about capping the price?
Did we think about, so I think this digital
okay, I got it.
Have we got thought of?
See, what did I say earlier? That the system will fail if the private doctors don't participate. So it's very easy to say ban this, cap that. But then the doctors stop participating, right? So while and this is not our view, this is the view of modern economics, that price capping in any environment, whether it is telecom or it is other economics, I'm not an economist, but I've talked to people who are experts on this. Price capping is not the way to control affordability. There have to be other solutions for affordability. Because if I put the doctor's point of view, I have studied for 15 years. I have given up my family life to do those night calls in my medical school and in my residency. And after 15 years, the patient is reluctant to pay me 200 rupees, but happy to pay 2000 rupees for a Netflix subscription. So there is a problem in our society. So I think price capping is not the way to go. True. Let the patient choose. So actually, this was a conversation that we have had with the leadership of NHA, and there was a view that by removing the friction between the patient and the doctor's discoverability, pricing will automatically start coming down, because there will be this young doctor who's sitting in a clinic who has 2 hours at his disposal. He's willing to see a patient for 50 rupees and not charge 500 rupees because he has the time and he's okay with 50 rupees. Today, that doctor is sitting locked in some clinic and not available to the country. But through UHI, the doctor is now suddenly available to 1 billion people who are searching for him. Power to him and power to that patient. And yet there will be a doctor who says, I am not going to see anybody below 2000 rupees. Power to that doctor and power to the patient who's willing to pay 2000 doctors. So in fact, there is no mechanism in UHI by which pricing can be capped. And we think that's a very important feature, because these are not these are not one-time transactions. You need participation from all players. And it sounds very, what should I say, altruistic that cap the price. But then what is the price that the doctor has to pay to learn those skills? We don't want doctors to say, I don't want to be a doctor. I'd rather be a technologist or a lawyer or an accountant, because medicine, you have all these price cappings. You get it done by whoever is available. So I don't think as a society we want to go there. We have to be very careful on that front.
Yeah, you have very rightfully said that, dictatorial approach is not going to make it succeed.
Yeah.
I think what has to happen is, yes, patients finding their doctor skill getting disseminated. And it's not about bringing down the doctor's fees. I would put it by saying that it has to optimize based on their consultations and their skill levels. And, this is where the water has to find its level. Exactly. Right now, that is not there. So in this whole term, it might look like a turmoil in the beginning while we're trying to fix the system, but water will find its level.
Yeah.
I think, and we might have doctors being paid 5,000 rupees for a consultant, somebody else 50 rupees, and it will all be, justifiable and on the system. So I think
I'll build on one other important point, Uma. You know that OPD insurance in India is sorely lacking.
Yes.
It is mainly lacking because there is no data. Insurers that I have spoken to say that I don't know how to give a 5,000 rupee policy and the patient claims 10,000 rupees in 2 months. Because he doesn't know what the patient has claimed for, and the paper handwritten thing that comes to the insurer is very difficult for them to process that. So our belief, and I didn't touch upon the health claims platform, etc. There's another big topic. Our belief is that once UHI has sufficient scale, insurers will come in and build OPD products on top of UHI, and that will also be a feature towards reducing pricing. So that's the innovation that I'm talking about, because data is available in digital.
That's the right approach that India is taking, which is exactly, I would say it's diametrically opposite what the Western countries have taken. And I found that it does not work because they do insurance first and then the digitization of data. Whereas it should be healthcare data first and then all the services on top. You're very right. So there is a question on, did we think of encrypted transmissions in cyber issues are an increased?
Or of course. I didn't go into the tech details, and when Mr. Kiran Anandampillai comes, but I will say that there is intense effort on this. We are well aware that healthcare data is prime target for hackers for various reasons. And fortunately, it's an arms race, between the hackers and the cybersecurity professionals. And cybersecurity professionals are pretty confident that not only from a hacking point of view, but also from a unwanted access to data point of view, this is going to be a state-of-the-art bulletproof system, mainly because, and I want to highlight this point because we have not talked about PHR, but this is a very important point. This is a federated data architecture. The data is not sitting in one server. If it is sitting in one server, that is the prime danger for hacking and for surveillance. If my Max report is sitting in Max and my Medica report is sitting in a Medica lab and my Manipal report is in Manipal, but I happen to be in Goa, and through UHI, I can pull these three and show them to Dr. Uma for a consultation. It is very difficult for hacker to hack my Max report and hack my Medica report and hack my Manipal report. So this federated architecture is a large piece of that security feature that we are trying to build.
Yeah, and also when it's available on a PHR, it's in the, the basic data is an encrypted form data which is available. So it's the only person who really has the entire data available to him is the citizen himself or herself.
Yes, and to those whom he or she have given consent. That's it.
Consent, yeah. So that's like, really a very secure method of doing this. So there are some questions which we have already answered in terms of insurance. There are questions regarding prescription and dispensation of psychoactive medicines on the telemedicine platform. So you want to answer that?
I can tell that. So the telemedicine guideline, the photo of which I showed, has 4 categories of medications. And actually, opiates are not allowed. Yes. And I actually think that's the right approach because even in the physical pharmacy, there's a very strict logging of the prescription and the dispenser. And I think the government is very thoughtful on that. and there will be an update of the telemedicine guidelines, but I will be surprised if they relax this condition. This is going to continue to be this one. We are all aware that United States is undergoing an epidemic of opiate addiction. So we have just seen a society where opiate caused deaths are now more than accident deaths. It's the second most common cause of death, third most common cause of death in the United States. So there's lots to learn from all the mistakes that the US has made. And I think Indian government is well aware of those and going to be quite strict about that.
Yeah, and I think over a period of time, I'm sure we'll evolve a methodology where these patients can also, their requirement can be addressed. But I'm sure there's going to be through another secure, loop, where another loop completely. So there are some other questions regarding how can I train my hospital staff to be ABDM compliant, and are there any training modules available for the government from the government for this?
So,
or there are private sector trainers that can help.
Yeah. Early days yet. I don't think so. Let me also talk about the technology stack for UHI. I'm talking about UHI specifically is getting ready in the next 2 or 3 months. There's going to be some pilot testing of the technology in the field in the hands of a few doctors, and then the scale up will likely to happen. I think it's at that point that this training modules and trainers will have to come in play, and I think 2022 will see a lot of action on these topics.
So, okay, there's a question about major changes in their IT systems requirement, which we'll take in the tech session and not today. But there is one on whether this will increase the patient registration and discharge time. Actually, what I think they want to understand is whether it'll improve the efficiencies, process efficiencies. So I think you can take in general about all the patient process efficiencies, and perhaps also on the quality indicators. You could just address that.
So just yesterday, I was talking to a former colleague who's now become a CEO of a large hospital network. And he has been talking to his doctors, and his point was that doctors don't get all the data because they write notes, they're locked into some other hospital system, patient doesn't have access to them. So the thinking of PHR and UHI is that it will reduce hospitals' workload. Let me give you an illustration of how that will happen. See, today when I am an oncosurgeon sitting in a large hospital and a patient comes to me with a file of 50 pages. This is the biopsy report from Calcutta. This is what the mammogram was done in Ranchi, and this is the surgery that was done in Calcutta. And now I had radiation in Vellore, and the oncosurgeon takes at least 1 hour to go through that. In the UHI story, there is also something called a data organization module, and we hope to invite artificial intelligence companies to come and organize that data for the doctor. So the doctor can get a summary of that. And in fact, Neurance, my tech venture, is working on that. And there are many other players who are working on that. So that's not a solved problem today, but there are tools in AI that are available to solve that. Therefore, we should expect a significant improvement in efficiency and not a worsening of efficiency or cost. If that happens, then again, UHI has failed in its fundamentals.
Right. Would the practitioners of alternative medicine also have access to these records?
Great point.
And vice
so
versa?
Remember, it's called the health professional registry. It's not called the doctor's registry. So any system of medicine which has a credentialing mechanism recognized by the government of India, which is all of Ayush, Ayurveda, Yoga, Unani, Siddha, Homeopathy. And I think now Tibetan is also a part of that. So all of these, as long as you have a central register of who are the accredited professionals, and those professionals have a UHI, SPR identity, I think the government is very keen to invite them into this, because actually I have personally spoken to a few of the experts in Ayush. It has a huge role to play in preventive medicine. And it has a huge role to play in management of chronic diseases where allopathy sometimes fails. So I think UHI eventually, once it's successful, can merge the preventive strength and the chronic disease strength of traditional systems and the acute care strength of the modern medicine into a unified care for the patient. Because guess what? The patient is in control. He or she can choose where they want to take the data and get their opinion. And that is again not possible in today's physical system.
Yeah, exactly. So, there are a lot of flaws, if I were to say, in the way we conventionally practice medicine. And it's not a flaw. I think I should call it gaps. So currently there are many gaps, and I think these gaps and our vulnerability on and dependence on this system was exposed during COVID more than anything else. And I think that's where we have suddenly realized that, had we got this game going, we would have been successful. So better late than never. So this is, really, these are the early days. And as you've just said that, okay, we will take a little while to really get this, put everything together. But it is necessary for our hospitals and the doctors to understand what is happening in this space. And we need to take more efforts, I think, also to train the doctors and the healthcare workforce. But as I see it, in a few months, once everything is done and all the pilots are done, it needs to reach a critical mass. Until then, it will look like nothing is happening. It's very slow. But once we cross that critical mass, it's going to be, the significant impact will be visible. Yeah. And that's where we would have won the game. And I think we should all be, very thankful to what is happening. And I think it's the very brave initiative of the government to really take this up. And thank you, Ajay, for spending time to explain to the doctors and as to what is in it for us, really. And now we are all going to benefit from this. So thank you very much. And I thank Nat Health for this. You have a closing comment before you want to leave?
No, my closing comment is, I actually think that doctors both have a responsibility as well as an opportunity to participate in this. Exactly. It's very easy to sit back and criticize the tech companies, but this playground is open for innovation. And I am a doctor, as you know, and I now have a tech company. I'm not saying all doctors should do that. All should not do that. We need doctors to be doing clinical medicine. But collaboration with technologists, which is proactive and solves clinical problems, is a need of the hour. And this decade of the 20s is going to see a revolution with progress in AI, with progress in robotics, that creates opportunities which were not there when I was in med school. So I think I would encourage more and more doctors to roll up their sleeves and look for tech collaborators with whom they can build new solutions that will solve these problems. So I think I'll close with that, and over to you. Thank you.
Thank you so much, Ajay. And I think this is an opportunity for the country. We are known for technology. We are known for our healthcare. And I think it is our moment in this world to really prove to the world that we have the best digital health system. And I'm sure the world is watching us. So eventually a lot of people are going to take lessons from us. So thank you very much. And I thank Nat Health for giving us this opportunity to speak to everybody. Thank you very much.
Sure. Thank you so much.
Oh, thank you. Thank you, everyone. And Dr. Bakshi, that was incredible. The way we started from, the CKD, and we covered so many aspects of the discussion. It was incredible. And thank you, Dr. Nambiar, for, asking the most apt questions and beautifully, moderating the session. So my special eye on behalf of everybody at Nat Health, thank Dr. Bakshi and Dr. Nambiar. I would also like to thank, Dr. Alok Roy, who gave his opening remarks at this session. Avian and Health Biz have been supporting us from the back end, so my special thanks to them as well. And I would like to express my gratitude to all the participants of the session and their questions. And if by chance we were not able to answer their questions, we would be posting their answers on our blog, nathealthseries.com. So please go and check it out. We will be back next Thursday on December 16 to cover another aspect of Ayushman Bharat digital mission with our legal experts. And we would be covering the topic of privacy, security, and confidentiality aspect of the ABDM. So stay tuned and keep reading more about all our webinar series and subscribe our YouTube channel. Thank you. Thank you so much and have a wonderful evening. Bye-bye.
Okay. Bye-bye.